Is Allison Hayden, and I'm a fourth-year DNP student in the School of Nursing. My project is on the relationship between colorectal cancer and obesity. Obesity is a risk factor for many cancers, and with the increasing rise in colorectal cancer in the younger population, I wanted to compare the two. Thank you for this opportunity to share my presentation. Colorectal cancer is the third most common cancer in the United States and is the third leading cause of cancer death in men and women in the United States. The United States Preventative Services Task Force has recommendations on when to screen for colorectal cancer. This includes all adults over the age of 50 using a variety of diagnostic tools. The United States Preventative Services Task Force recommendations have caused a decrease in colorectal cancer. While the current recommendation is to screen all individuals at the age of 50, cases of colon cancer and rectal cancer are increasing among young and middle-aged adults in the United States. Many cases are going undiagnosed because up until now, it was very uncommon for young and middle adults to have colon cancer. In the United States, over 1/3 of adults are obese. Being overweight and obese are risk factors for developing certain cancers. As a reminder, body mass index for normal weight is 18 to 25. Overweight is 25 to 30, obesity is 30 to 35, severely obese is 35 to 40, morbid obesity is 40 to 50, and super obese is 50 plus. In 2008, the estimated annual medical cost of obesity in the United States was $147 billion. With the rise in obesity rates and the increase in cancer, research is now linking the two. Many researchers explored the relationship between colorectal cancer and obesity. Because obesity can have many causes, articles investigated BMI, waist-to-hip ratio, waist circumference, visceral abdominal fat, hyperinsulinemia, postmenopausal status, physical activity, and many other contributing factors. It was difficult to find current primary research articles that compared men and women of similar age while investigating the same risk factors. In order to keep things simple for the purpose of this presentation and paper, with the three articles focused on BMI and waist-to-hip ratio and its relationship with colorectal cancer. Colon cancer has been described as colon cancer, colorectal cancer, rectal cancer, colorectal adenomas, and advanced neoplasia. The primary aim of Study 1 was to evaluate the increased risk if the increased risk of colon cancer associated with obesity differs for men and women by distribution of body fat or by location of the tumor. This study was done by Moore et al. In 2004. The exposure was obesity measured by BMI and waist circumference, and the outcome was colon cancer. The cancer was diagnosed using a standardized protocol. The large study used eligible subjects from the Framingham study cohort. They viewed subjects during 2 different age periods and were followed for the occurrence of colon cancer. For the purpose of this project, the age group viewed was 55 to 79, and the cancer location included all areas of the colon. Study strengths included very large sample size of men and women and the longitudinal nature of the Framingham study. Using the Framingham study cohort helped reduce bias. While the Framingham study can be seen as a strength, it can also be seen as a negative. The authors were not able to explore other obesity risk factor mechanisms, including dietary intake, and they were not able to explore the effect of family history and know the age women entered menopause. Study 2 was done by Stein et al. In 2010. The aim of Study 2 was to examine the predictive value of obesity for colorectal cancer, adenomas, and asymptomatic patients. While this was a large study sample, it had the fewest amount of participants compared to the other studies. The study sample was different in this study because the participants were closer in age. This is because the participants were selected because they were of age to need to complete a colonoscopy. The participants were ethnically diverse. The exposure is BMI and obesity, and BMI was measured. The outcome is colorectal neoplasia and was measured with a high-definition colonoscope to detect colorectal adenomas. The study strengths included a large sample size of ethnically diverse population. Over 23% of the population defined their ethnicity as Hispanic. One endoscopist was used to scope all participants using a high-definition colonoscope. This helped reduce bias. Many factors were reviewed in this study. Study limitations included confounding bias. While this study viewed many variables and risk factors associated with obesity and colon cancer, other confounding factors may still be present. Study 3 was done by Pichon et al. In 2006. The aim of this last study was to examine whether body fat distribution is related to the risk of colon and rectal cancer. The sample size was very large and the exposure was obesity measured by BMI, waist-to-hip ratio, waist and hip circumference. The outcome was colon and rectal cancer measured by the documentation in the cancer registries and pathology reports and information from families. Study strengths included the large sample size and prospective design. All measures were taken at baseline and were not self-reported, reducing bias. Although, because of the large sample size across many countries, these measurements were taken across many centers. Limitations included differences in the method of assessment used to measure waist and hip circumference between centers. The 3 articles had many different variables to find association between obesity and colorectal cancer, including different BMI range and age. To get an accurate comparison between the 3 articles, I compared a BMI greater than 30 and then the 50 to plus age group. In Study 1, the Framingham study, in patients aged 55 to 79 with a BMI greater than 30 had a 2.4-fold increased risk of colon cancer. The BMI effect was stronger for men than for women and for cases in the proximal colon. These effects generally diminished when waist was added to the multivariable models. An extra-large waist circumference had a relative risk of 2.6 of developing colon cancer. Both of these risks had a moderate strength of association and were independently predictive of colon cancer. The findings show a stronger association between waist size and colon cancer versus BMI and colon cancer. In Study 2 by Stein et al., all participants were viewed with a multivariate analysis with an odds ratio and a 95% confidence interval. Participants with a BMI greater than 30 had an odds ratio of 3.83 of advanced neoplasia. This is a strong association. In this diverse study population, the authors concluded that obesity was associated with an increased risk of any adenoma and advanced neoplasia. This association was significant after controlling for age, smoking history, family history of colorectal cancer, aspirin use, and exercise. In Study 3, all anthropometric measures measured, waist-to-hip ratio showed the strongest association with colon cancer. Waist-to-hip ratio was positively related to colon cancer risk in both men and women. In the largest waist-to-hip ratio category, men had a relative risk of 1.55 and the women's risk was 1.06, both having a moderate strength of association. Among men, weight and BMI were associated with a higher risk of colon cancer, but not among women. When measuring BMI in the highest or heaviest category, men had a moderate strength of association and their chance with a 95% confidence interval was 1.12 to 2.15, making it statistically significant. The women's chance was 0.79 to 1.42, therefore not statistically significant. The study found no statistically significant association between body size and risk of rectal cancer. Study 2 was the only article out of the 3 that was able to find a strong strength of association between BMI and colon cancer. I believe this is because the authors used an ethnically diverse screening population. In Heineken's criteria, Study 1 and Study 2 group, the results for men and women. Unlike the first two studies, Study 3 lists the results by gender and does not calculate a measure of association for the overall sample. Because of this, it was difficult to completely compare the studies. That is why I attempted to report similar results for the rest of the data, including the 50-plus age and the largest BMI, waist circumference, and waist-to-hip ratio for each study. Study 1 and 2 showed results to be statistically significant. In Study 3, the waist-to-hip ratio showed that abdominal obesity is equally strong risk factor for colon cancer in men and in women, and in men but not women. This is because the chance includes 1, so it is not statistically significant. There were different types of bias for each study that are listed here. All 3 studies had many confounding factors that could attribute to obesity and colorectal cancer. The factors are listed and whether they were controlled or not controlled in each study. Like discussed in the previous slide, in Study 3, there is no strength of association between BMI and colon cancer in women. Study 2 found a strong association between BMI and cancer, and Study 1 found a moderate strength. Study 2 is the only study without temporality because cross-sectional studies cannot show temporality. Abdominal obesity is equally strong risk factor for colon cancer in men and in women. In ethnically diverse populations, obesity was associated with an increased risk of any adenoma and advanced neoplasia. Obesity may represent a risk that justifies beginning screening at an earlier age in order to reduce progression of colorectal polyps to cancer. According to the recent study by the American Cancer Society, people younger than 55 are 58% more likely to be diagnosed with late-stage disease than older people. The author says this is largely due to the delay of follow-up symptoms, sometimes for years, because cancer is typically not on the radar of young adults or their providers. These results are especially important for providers. There has been a discussion whether to start screening for patients for colorectal cancer before the age of 50 due to the increase in prevalence in the younger population. It is important for providers to be alert to the signs and symptoms of colorectal cancer and screen patients, especially if they are obese. Future research should be done in the United States Preventative Services Task Force recommendations on when to screen for patients. After reviewing these articles and finding a strong relationship to colorectal cancer and obesity, the possible recommended age might be 40 years of age if the patients are obese. This is something that should be looked into and more research needs to be done. Because obesity is a risk factor for many comorbidities and cancers, the main goal is prevention. For those patients that are overweight and obese, early treatment is key. Thank you very much for your time and the opportunity to share this information. Please let me know if you have any questions.